Hello, and welcome to this short webinar on airway management in companion animals. My name is Sheppard, and I qualified as a veterinary nurse back in 1987 now. I've been with Dots in Events since 2012 as their product specialist, and I'd like to take you on a journey. Our first question is, why do we actually need to concern ourselves about gaining a patient's airway? It's really all about safety. By having a safe, secure, patent airway, we can deliver not only volatile anaesthesia and/or oxygen, but we can also provide good manual or mechanical intervention if required. Safety for our patients in respect of achieving a fluid seal, protecting against aspiration of any dental fluid or gastric reflux regurgitation that may occur. And finally, safety for the staff in the room. By securing the sealed airway allows for scavenging and less environmental pollution. Is there a situation whereby having no airway management is a feasible option? When a patient is anaesthetised, they will have no control over their airway. So if loosened food, reflux material, or dental water were to touch the larynx at a suboptimal plane of anaesthesia, a laryngospasm is possible. If the patient is at an optimal plane of anaesthesia, then the material could very easily fall onto and occlude the airway. Either situation, your patient is now in trouble, and it's much harder to gain an airway in an emergency situation. We hear many excuses, such as endotracheal intubation takes longer than some surgical procedures. The Broadbelt Confidential Inquiry into Perioperative Small Animal Fatalities indicates intubation in young, healthy cats increases trauma and mortality rates. This is not a reason not to obtain a secure, safe airway. Just look at other options that are available to you. How many of you oxygenate all of your patients? The trend seems to be only for small exotics and brachycephalic dogs, but all patients should have access to 3 to 5 breaths of 100% oxygen. This will increase the body's oxygen stores, buying yourself time to gain an airway should the patient be compromised. We don't always check the larynx or pharynx of our patients before anaesthetising. If there was a foreign body, a tumour or a deformity that could impede placement of an airway device, your patient is slowly desaturating.
The trachea is lined with ciliated mucosal epithelium. Mucus is produced by goblet cells and submucosal glands. The job of this mucus is to entrap foreign material and infectious particles such as bacteria and viruses. These mucus globules are then actively passed by beating waves of cilia up the trachea to the pharynx, expelling them from the respiratory system. This process, the mucociliary escalator, is a vital part of the immune defences of the animal. During the process of intubation, studies have shown that the tip, the body and the cuff of the endotracheal tube strips the cilia from the epithelial surface. This creates areas where the mucociliary escalator no longer functions. Bacteria and other infectious organisms can no longer be removed from the lungs.
We don't normally have the luxury of looking at the trauma caused by endotracheal tubes, but the grazing, splits and inflammation is easily visible, seen here using a bronchoscope. Vets and nurses intubate patients on a daily basis, 3, 4, 5, 10 times a day in a busy clinic maybe. A patient, if it's lucky, may have an anaesthesia once or twice in its lifetime. So owners often worry about the changes they see, the coughing, the voice changes, the difficulty giving tablets, and certainly with rabbits, difficulty with feeding. Unfortunately, social media plays a part here, and many worried owners will post on sites such as catsters.com, vetinfo.com, and often ask for other owners' advice rather than going back to the clinics. So let's look at some of the techniques that could improve both our patients and our own experiences of airway management. First up is lubrication. How many of you actually lubricate devices before placement? Certainly with endotracheal tubes, it's very clinic or even vet's own personal preferences. Using a spray bottle keeps excess applied lube to a minimum, but sachets and tubes are available. But application from these should be via a gloved hand or a swab rather than directly onto the device itself. Lubing devices will certainly make them easier to place and reduce the trauma, but also in the case of endotracheal tubes will improve the seal and reduce the volume of air inside any inflated cuffs. This is perhaps a controversial point, but an important consideration. Many vets and nurses are taught not to place the endotracheal tube beyond the thoracic inlet. But placing the ET tube so far down the trachea not only causes extra unnecessary trauma to the tracheal lining, but risks over-insertion, possibly inflating only one lung and causing potential bronchospasms. Having no seal at the upper airway also gives no protection against the aspiration of fluid, dental water or reflux. Inflated cuffs can help, but if placed at the caudal end of the trachea, allows more fluid to collect above, which is then aspirated on deflation and extubation. In order to keep the inflated cuff higher up, we need to use the vocal cord markers on the tube and cut the appropriate length for the patient. By sealing higher up in the airway, this reduces the potential volume of accumulated water. On selection of the correct size device and a cut-down ET tube to the appropriate length for your patient, you can now secure it more effectively. By tying around an ET tube itself, the bandage or IV line can slip, and if the device is not supported well, can be pulled out easily. Small wings on both ET tubes and V-gel connectors allow them to be included in the tie-in. Please avoid elasticated material for ties as they allow excess movement of devices. So let's talk about supporting your circuit. These are often very heavy for our veterinary patients. Old techniques used to see the circuits tied or pinned down onto the tables, causing the airway devices to be pulled into unnatural positions, causing additional trauma or even loss of established airway. As indicated on the left image with the superimposed ET tube, most airway devices depart the mouth at an angle of 45 degrees. With support, the circuit can be brought to the airway device connector, allowing us to maintain this angle without inflicting the previously mentioned issues. Any rotational movement of the patient should see the circuit disconnected before this movement occurs. Do you wear gloves? If not, why not? Apart from the fact you're placing your hands into your patient's mouths, probably the most bacterial-ridden orifice of their body, you're potentially contaminating the traumatized tracheal lining if you're using an ET tube. Devices should be kept in a clean, dark, dry storage area, and when used, kept in a clean area until placed into the patient. Whilst under general anaesthesia, the patient's body relaxes, and this will include the upper and lower sphincters of the stomach. Yellow bile or brown gastric contents can move, ebbing and flowing up and down the esophagus during the procedure. On reaching the upper esophagus, if the fluid tops into the pharynx, then it can track down into the lungs. Often occurring silently, this reflux is only evident if it's seen in the mouth or the nostrils, but normally lies undetected until the patient recovers from the anaesthesia. The incidence of reflux and regurgitation is multifactorial. It includes procedures that directly inflict pressure onto the stomach or the small intestines, pushing the contents directly up the esophagus. Extra pressure with the diaphragm pushing directly down onto the stomach during IPPV. Deep-chested breeds, thick-neck breeds, and obesity all increase the incidence. If the patient is in dorsal recumbency, the head could be tilted too far back so the nose is touching the table. This gives easy access for drainage of fluid directly into the pharynx. And extended fasting times. Latest research suggests that no more than 5 hours of food withdrawal before anaesthesia is done. Watch the upper right hand corner of this video. Brown stomach reflux exits the dog V-gel during trials whilst we were recording seal pressures. Had this been an ET tube in place, this stuffy spay may not have been so lucky. Let's look for a moment and remind ourselves of the ET tube cuffs and look at how much protection they actually give our patients against aspiration. High pressure, low volume cuffs is in your red rubber tubes are like wearing your stilettos at weekends. All your weight on a small surface area basically equals sore feet. Low pressure, high volume cuffs, as in your PVC tubes, are your nice flat shoes, much more comfortable, but as less pressure, they may leak and they can give gaps, especially if they are hardened after reuse. Once fluid accumulates above the cuff, dripping down from the unprotected glottis, it can seep through the tracks left in the inflated cuff. Studies show that the amount of protection is totally random, as is the folding patterns of the cuff itself. At only 10 centimeters of water pressure, we get 10 minutes of protection, and leakage occurs in all conventional ET tubes up to 60 centimeters of water pressure. Given that venous perfusion pressure is only 16 to 24, this is way above the safety line.
Many endotracheal tubes have an inflatable cuff. This cuff is designed to press against the tracheal wall to seal the airway during ventilation. The process of cuff inflation can unfortunately compress mucosal vessels. Compression of the blood supply can result in extensive mucosal necrosis. This might result in anything from throat pain and an increased risk of infection to a complete tracheal rupture.
On a good day, we may cause a little inflammation of the trachea and our patients may cough for the next week. On a bad day, we could overinflate, cut off complete blood supply to the wall of the trachea, and our patients may return with emphysema due to a breakdown of the tracheal wall. Some quick visualization of some of the trauma that we can cause on overinflated cuffs. Due to most veterinary staff guesstimating the volume of air required to inflate cuffs in order to achieve a good gas seal, numerous studies show that we are causing unnecessary trauma to our patient's airway. And as a final note on ET tube cuffs, be aware that as they harden with the reuse, they do not lay flat against the body of the tube and can cause irreparable damage to the larynx on removal. So let's have a closer look at the alternative airway device. The first laryngeal mask was introduced way back in 1987, and the subsequent iGel supraglottic airway device followed in 2007 after 19 years of research. The same inventor, Dr. Mohammed Nazir, brought out the first V-gel designs for our cats and rabbits in 2012, and the new V-gel Advanced launch will be in 2020. These devices achieve a sealed, safe airway in our veterinary patients without touching the larynx or the trachea at all. The soft bowl mirrors the special anatomy of the patient and seals at both the upper esophagus and the larynx. There are many benefits to a supraglottic airway device. I think the most common one I hear from people is that they are so quick and easy to place. Often comments such as, was that it? Was it that easy? And people can't actually believe that they've placed the device in a live patient very quickly. I can show you by using one of our models here with a lubricated V-gel. It is a case of simply putting the V-gel on the tongue of your patient and literally pushing. These shoulders at the end will automatically stop up against that paraglottal arch, that skin at the back of your patient's mouth, and will stop you pushing the V-gel further in. The V-gel itself is sited then in the upper esophagus. This is going to stop and block your fluid coming up from your stomach, potential for aspiration. It's also going to stop the gas and the anaesthetic going down to inflate your patient's stomach. The V-gel itself sits mask sited over the top of the airway channel. And because the airway channel, the airway device itself, is not going down the trachea, we don't get the problems with the trauma of the trachea, the trauma of the larynx. It doesn't induce laryngospasms, and the internal diameter of the channel of the V-gel is designed to be the same, if not more than, the tracheal diameter of your patient. So we get no airway resistance. And probably the most safest thing is that because we get a much greater seal pressure than we do with an ET tube, we actually have a lot more health and safety benefits. As there's no leakage into the environment, it gives our mothers-to-be that little bit more peace of mind and security that they're not going to have environmental pollution. So let's take you through the anatomy of the V-gel Advance. From the connector end, we have a low dead space connector. This is going to be much improved against our small patients, very small rabbits and our small cats. We have some ridges on the end of the device. This will help secure your IV lines, your white open wove bandages, wrap around the wings of the connector and then round the back of the animal's head, which will help it secure in place. Airway channel runs up to these shoulders, and these shoulders are going to give you that stopping point against that paraglottal arch at the back of the patient's head, and this is going to stop you overshooting your airway channel. The bowl itself actually sits into the pharynx and rather than sitting directly on top mirroring the larynx as the old V-gels, the original V-gels used to do, we now have a small skirt on the V-gel, and this now gives us the advantage, but by cuddling effectively the larynx, we now get a much better seal pressure. And again, we've still got the esophageal seal at the end, which is going to secure our airway against air going down to stomach or aspiration, potential aspiration of stomach contents coming back up. So let's take you through the new Rabbit V-gel in a little bit more detail. When you look at the old V-gel to the new, I think the biggest thing, the first thing that jumps out at you is the bowl shape. We've now got a much wider entrance to the V-gel, walls are much thinner, and a skirt on the V-gel. It's also much softer. Now all this means by having a much thinner wall, we have much more space within the bowl itself. We used to occasionally get some noisy breathing when you put the original V-gels in, and some feedback back from customers meant that what we were seeing was a folded epiglottis. Because now the new V-gel has much more space for that epiglottis to move naturally, we don't appear to get that noisy breathing, and the folded epiglottis seems to be avoided. Because the V-gel is much squishier, it's much softer, we don't see that pressure on the back of the tongue that we would occasionally see in the original V-gel. And these blue tongues, this lingual congestion, is definitely minimised. Because the V-gel is sucking around or cuddling around the larynx, we're actually getting much better seal pressures. So positive pressure ventilation, whether it be mechanical or manual, is definitely better. The V-gel allows for a greater range of size of patients than the original V-gel used to be. It's a little bit more forgiving if you accidentally select the slightly smaller device for your patients. Going along, the device itself from the shoulders that stop you overshooting the device now comes down, and this mouth part is much thinner. This allows for a lot of movement and a lot more space in the patient's mouth for dentals. And the other thing we've done on the rabbit V-gel is when we get to the connector, we've actually taken out on these tie-in rings, we've taken out a section at the top and the bottom. So if you have got a patient with very long incisors, you're not going to get a false stopping point. Those ridges are not going to stop you pushing the V-gel in far enough. And again, our low dead space connector on the end is going to help our smaller patients. So now let's have a look at the cat V-gel in a little bit more detail. We get a very similar advantage with the cat V-gel as the rabbit one on the V-gel Advanced, in the fact that we are now cuddling the larynx, we get much better seal pressures, and we've again narrowed down this airway channel, giving much more accessibility for placement of X-ray plates and accessibility for dentals. One of the big differences in the cat V-gel to the original is the loss of this dorsal balloon that we had with the original V-gels. We found that cats with brachycephalic cats with a high soft palate with the old V-gels, because they sat directly on top of the larynx, we sometimes, when we did IPPV, we used to have the V-gel lift up into that void of the soft palate with our brachycephalics. The improvement of the new V-gel Advanced and this skirt, where we're actually cuddling the larynx, means that we get much better seal pressures. So we avoid the need to inflate, and again with the issues of venous perfusion pressure, we don't want to be unnecessarily inflating against any unnecessary tissue. These now are suitable, therefore, for all types of head shapes, whether we're looking at a brachycephalic cat or the long dolichocephalic cats. We don't have the need for the different length devices that we had with the original V-gels. Again, these airway channels have actually been designed that it doesn't matter what head length or muzzle length your cats are, the V-gels actually will suit very well. With your cat size choices, you'll notice that we have increased the range of V-gels to include both smaller and larger cats than previously covered. This allows you to include all of the much smaller kittens down to 500 grams and also the larger breeds. Don't forget, these are ideal body weights, maybe not actual if your patient is slightly over or underweight. And here are your rabbit size choices. You will notice with the previous cat and this rabbit size guide, there is a bit of an overlap with the patient size against the V-gel device. As with any airway device, you select the larger size and reduce if necessary. So as an example, if I had a patient of good body condition at 2.7 kilos, then my first size choice would be an R4 with a fallback of an R3. The V-gel Advanced is a single-use device available in outers of 5. With very competitive prices, most clinics will hold all size ranges to cover all patient sizes. So you now have a choice to make. Which airway device do you use? Different patients and procedures will call for different devices. The V-gels are currently available for rabbits and cats, with the dog devices to follow soon. So this may simply be your current reasoning for your airway choice. V-gels are ideal for most routine surgeries, especially where endotracheal tubes are considered too risky or traumatic. Bronchoscopy and bronchial lavages are ideal procedures for V-gels, as too are dentals. I would certainly fall on the side of an ET tube when you suspect a collapsed trachea or need to pass a gastroscope. Any access to pharyngeal area would also be impossible with a V-gel in place. Resuscitation is a no-brainer. All emergency crash carts should have a good size selection of V-gels. They can even be placed when a laryngospasm is happening on recovery from an ET tube extubation. So in summary, airway management is such an important factor of the anaesthesia process, and it's not a race to intubate. Assess your patient, procedure and select an appropriate airway device, and be prepared with several options if the first choice is unable to be placed. And don't cut corners. Follow the rules and practice safer airway management. Look after you and your patient. Our V-Gel journey has been amazing. V-Gel, since their launch in 2012, have been sold to over 30 countries around the world, 27 of which have established distributors. They have been placed and are taught in over 60 vet schools around the world, and they're included in most of the new veterinary anaesthesia publications. We are so proud to hear that they are independently presented at many specialist meetings worldwide. And the journey doesn't stop there. You can find much more information on all of our products, including training, at www.docsinevent.com. Keep following us on Facebook. We'll give you much more information and updates on our Facebook page, Docsin Event Limited, the home of V-Gel. I would thank you for your time today. I hope you've enjoyed our very short look at airway management, and I thank you for the time. I hope to see you all soon.